And today we're going to be talking about institutional racism in Australian hospitals and healthcare settings. Just a little bit to tell you about me. For those who don't know, I'm a dentist. I've been in public and private dental practice for over 35 years in both remote, rural and capital cities around Australia. I've got a range of qualifications apart from my dental degree. I've also a former MLA in the ACT Legislative Assembly. I'm a past president of the Indigenous Dentists Association, a past president of the ADA here in the ACT. I was on the ACT Dental Board. I'm a member of the Campaign for Indigenous Health Equality, Close the Gap. I'm a member of the National Health Leadership Forum, and I'm also co-chair of the ACT Reconciliation Day Council. And in my spare time, I'm the spokesperson for the National Oral Health Alliance. And here's the sites around Australia where I've practiced dentistry, so you can see that I've possibly been somewhere near you, apart from you people in the Western Australia and Tasmania, but there's no Tasmanians in this project. So I'm sorry I haven't had the opportunity to practice in Western Australia yet, but it's still on my ticker box. So, what are we talking about? We're talking about Aboriginal and Torres Strait Islander healthcare disparity. We know from the last Close the Gap report that 53% is due to social determinants of health and risk factors, which leaves the remaining 47% due to interpersonal racism, institutional racism, intergenerational trauma, and a lack of cultural safety. What does that mean? Well, you can see from this graph where Indigenous Australians have a significantly lower life expectancy at birth compared to other OECD countries, including Australia, which is in the red bit in the middle. And then you look at mortality differentials across a range of diseases. The one we're most interested in this project is ischemic heart disease. And you can see it's a major killer, but you can also see the bigger differentials actually around diabetes. And these are differentials between Indigenous and non-Indigenous people. So we're going to talk a little bit about race. And when I start this conversation, it's always good to preface it with this great quote from Chelsea Bond, a proud Queensland woman, who tells us that expecting comfort in conversations about race is unrealistic. We'll go through a couple of terms that you may or may not have heard about. We're going to talk about individual racism, racial prejudice, white privilege, institutional racism, unconscious bias, cultural safety, and decolonisation. Primarily, we're going to talk about institutional racism today, but I just want to unpack these other ideas because people have heard them and they want to know how they fit into the overall scheme of things. So, fundamentally, racism is the expression of a particular person's belief in their superiority because of their race and their compulsion to maintain the power of their racial group over others. Racial prejudice is about that unthinking negative beliefs about people from other racial groups. As I say, everybody's prejudiced, but for some people, what they do about that prejudice makes them racist or not. So, quickly, individual racism, it's that overt interpersonal stuff that we're all reasonably familiar with. It's about the actions and words and the interactions between people. And fundamentally, going back to the previous idea, it's really designed to maintain the avoidable and unfair inequalities across groups. Unconscious bias, well, it's really just another name for racial prejudice. And for those of you who are interested in looking at this further, there's actually something you can Google called implicit association test from Project Implicit, which is well worth a look at. And you can actually check your own unconscious bias across a range of groups. White privilege, well, that's the other side of discrimination. It's been described as the invisible knapsack that white people have, really hard to see for those who are born with it, and it's the benefits given to those who resemble the people who dominate the powerful positions in our society. And there's a couple of quotes that express what white privilege is about. It basically says that having white privilege increases the odds of you having things your own way. Being able to say what, for instance, as has happened recently in this country, what is racism or not, and being accepted that that's the way that things happen. Decolonisation, and of course that great quote from last year, why is history a mystery? I mean, decolonisation requires an understanding of Australian history and what it's been. We know that Captain Cook turned up in 1770 and started shooting within 5 minutes, and that's actually in his journal. We had an invasion in 1788, and there was that conflict over resources for land, water and food that resulted from that. There was dispossession with violence for over 100 years. And here in New South Wales, Governor Macquarie declared martial law. We had that federation happen with the Constitution in 1900, which explicitly discriminated against Aboriginal and Torres Strait Islander people. And then we had all that stuff with the stolen generations. We had massacres in the 1920s in the Northern Territory. Mounted Constable Murray, a Gallipoli veteran, rode out from Alice Springs and slaughtered 100 Waterbury. We had race control laws that controlled your life, about who you could marry, where you could live, who you could associate with. And we had particularly the episode of the stolen wages in Queensland for 50 years of the government taking away people's money that they then doing work, not necessarily for the government anywhere, because they are Aboriginal. And we even had racism in hospitals, but we're all familiar with in the stories in this project about the separate door at the back of the hospital for Aboriginal people up to the 60s and even 70s. For people who want to know more, the Little Red, Yellow, Black Book is a great resource. It's very inexpensive and you can get it from Linux. And there's that great poster from National Reconciliation Week last year. Now let's get down to tin tacks of what institutional racism is about. It's covert, which means you can't see it when you go into an institution, and it's how an organisation manages to deliver different outcomes for some groups in society. Particularly, we're going to talk about Aboriginal and Torres Strait Islander people. And it's about the way organisations are governed, staffed, resourced, operated and held accountable. The exclusion of some groups from those elements means that they get poorer outcomes. And it's got absolutely nothing to do with staff prejudices or actions. And that's important to understand that, because training and development doesn't help. First described in 1967, primary characteristic is that outcome discrepancy. And those further trays have been hidden. It's integrated into the way the organisation works. It's got nothing to do with how the staff behave, and whether people mean to do it or not doesn't matter. For Aboriginal and Torres Strait Islander people, we can see these results. Less likely to get treatment for cancer, disparities in eye cataract surgery, elective surgery, longer times. We know what happens in hospitals with coronary care, but there's also kidney transplants, and PBS expenditure, that's pharmaceutical benefits expenditure for Aboriginal and Torres Strait Islander people, is 33% less than what's spent on non-Indigenous people, even though they're sicker. So what do? There is an external measurement tool available that uses only publicly available information to provide both transparency and verification. It's a matrix of 5 key indicators. Are people included in government? Are Aboriginal people considered in policy implementation? Is there service delivery? What's happening in employment? And really interestingly, financial accountability. Where does the money go? So the inspiration came from someone else's work. It's been designed as a desktop tool, and it's about quantitative measurement, because that attracts attention. So what does inclusion in governance mean? Well, for a start, it means are Aboriginal Torres Strait Islander people empowered in the relevant health law? And there's a couple of acts from Queensland. The legislation could include that people need to be represented on boards. And we've heard recently from in the selection campaign about people talking about Aboriginal and Torres Strait Islander people being included on PHNs. I was in South Australia last week, and the South Australian Minister was talking about every LHN, every governing body for South Australian Health, having an Aboriginal or Torres Strait Islander person on their board. So representation on boards. And is there a board committee set up to help Aboriginal people to have a say? Inclusion in management. Is there an Aboriginal and Torres Strait Islander person in the executive? Is there a set division or department? Is the AMS ACHO represented? How is the local community involved in determining the nature of this inclusion. And then what are the policies? Well, we know there's a raft of policies out there that are available that should be taken into account in the governance of any hospital and health service. Is the community engaged? Is there a reconciliation action plan? Is there a community reference group? What about the public reporting and accountability in the annual reports? There could also be regular bulletins to the community. And what you'd expect to see is reporting on closing the gap progress, reporting on Aboriginal and Torres Strait Islander employment at the service, any special achievements that have been undertaken. And all this is designed to help Aboriginal and Torres Strait Islander people feel that the hospital is theirs and operating on their behalf to meet their needs, because that's fundamentally what accountability and public ownership is. Is there a local Aboriginal and Torres Strait Islander health plan? And what about cultural competence, cultural safety? What's happening here? Has there been training? Is there someone paying attention to how this is delivered? And then look at some of those health system performance indicators. We've probably only really got a few really good ones, and that's, well, we've only got a few ones that are not necessarily very good, but potentially preventable hospitalisations, discharge against medical advice, Aboriginal and Torres Strait Islander people in the workforce, staff retention, competent governance, Aboriginal and Torres Strait Islander people training for health positions. And then looking at health workforce development. So not only do they have a workforce, but are they working to develop them? Are people having, is there equity across the various professions and employment categories within the service? And then we're looking at that participation in the workforce and all health-related positions within the hospital. And then we're looking at the Commonwealth funding contribution within the area of financial accountability, because transparency and accountability are the hallmarks of responsible government. Are the financial statements routinely reporting what is allocated to Aboriginal and Torres Strait Islander healthcare? Hospitals should show their budget allocation from the Commonwealth against the Aboriginal and Torres Strait Islander health priorities, as well as state or territory inclusions, which is the next bit. Following the money. This is really important for people to see what's actually going on. So there was a study done at Cairns and Hinterland Hospital and Health Service back in 2014. It looked across those effectively 36 measures across the 5 key indicators and found that there was a total score of 14 out of 140, which translated into a level of institutional racism which was extremely high. And then we went back in 2018, last year, and found it to be quite a bit of improvement, and it was now very high, bordering on high. So they've managed to accumulate 25.5 points in 4 years. So what did they do? They appointed an Indigenous person to the board. They established an Aboriginal and Torres Strait Islander Health Community Consultation Committee. They re-established the Executive Director position, which had previously been abolished under the Newman government. They started reporting on discharges against medical advice and found potentially preventable hospitalisations for Aboriginal and Torres Strait Islander people. And they established an Indigenous trainee program. What they didn't do and haven't done was financial accountability. Now, it's interesting that Torres and Cape, which is the Health and Hospital Service, which is immediately to the north of Cairns.
How are you, lovely? Long time
Hello, somebody needs to mute there if they could, please. Torres and Cape.
Enjoy all that? You'll have no time off, you know. You wouldn't feel like it when you came back to your mountain of work, though, I'm sure.
Dasha,
hello, I think somebody needs to mute their phone there.
Yeah. Dasha, you're not muted.
Wow. Yeah.
There's a conversation happening. Anyway, financial accountability. Torres and Cape detailed the allocation of $9 million of state and federal funding to 20 programs in their annual report.
Okay, cool.
And they were the only Queensland HHS to do that. The other thing the Cairns hadn't done is they hadn't done anything about the employment issue, or they hadn't talked about it.
No, that's
so their
okay.
staffing numbers were unreported.
Well, what I might
even though 30% of
the
population in around Cairns is Aboriginal and Torres Strait Islander. The hospital employs nearly 6,000 staff, which with employment equity would actually equal approximately 600 Aboriginal and Torres Strait Islander people.
If I wanted to get Velcro,
and that's it, which gets us to some questions.
Things to the wall.
Please caller 07 because they're speaking over you. They're talking over you.
Who's that there?
Caller 07 on my screen is talking over you, Chris. And it's really disturbing the presentation.
I just go grab it myself.
I don't know how we can do anything to do about that. Penny, can you help with that?
Yeah, I can't imagine there much. And
oh, they're gone.
That's better, I think.
Yeah, that's great.
Good.
I found the screen that shows me to do that. Super. Whoever fixed that was very good. Any questions?
This is Ronnie from Perth. Listen, it is a problem, I think, institutional racism, but how do you prove it?
Okay.
How do I
That's
go
why,
to my and say...
That's where this matrix comes into play. It's already been tested in the Queensland situation and is well documented there. And if there's more information on the Queensland Anti-Discrimination website, or I can, indeed, if you send me an email, I can send you the links to the information there. We've also just started working with South Australia, with the South Australian Health Performance Council, because they wanted to implement a South Australian version. So there is a measurement tool available which can show where this is happening. The upshot of what does it actually do? Well, we've seen all those things which happen in hospitals that produce poorer outcomes for Aboriginal and Torres Strait Islander people. There was that Medical Journal of Australia article last year which talked about differentials in kidney transplants and pointed out that there was nothing to do with the patient or their circumstances or the type of the disease which was producing poorer kidney transplant outcomes for Aboriginal and Torres Strait Islander people. It was about the policies in the hospital, which is clearly a site of institutional racism. Another study that came out a couple of years ago was from Melbourne Eye Health, which looked at cataract operations rates, which are very low for Aboriginal and Torres Strait Islander people. Optometrists from the community were relocated into an Aboriginal medical service with no additional training or cultural competency training or anything like that, just put directly into AMSs, as a result of which, operating in an environment which had much lower, very low levels of institutional racism, suddenly the cataract surgery rates increased significantly. So there's two examples of the theory in action. So there's a measurement tool available. We can see it's actually working. The question is your board and CEO, who are the people responsible for this kind of organisational culture, going to take notice and engage? And how do you, as a worker, stimulate that? That's a big question. Does that help?
Yeah.
Good.
Thank you.
Chris, it's Karen from the Heart Foundation in Queensland. Is there somewhere on your website where you have hospitals that you've ranked in regards to how they perform on the matrix? Sort of like a rank a brand kind of system where you can actually rank hospitals based on whether they've even undertaken such an investigation?
Well, the really clever thing about the matrix is you don't have to do it internally, because it's all dependent upon public documents. You just go and look at their annual report, which is published. You look at their hospital and health service agreement with the state government, which is published. You look at their strategic plan, which is published. You look for other elements like a RAP or other agreements which are publicly available on their website. And from those, you can actually do the ranking, because this is fundamentally about saying it needs to be accountability, needs to be open. So if you've done something but you're not telling anybody, that's not open. The answer to the question about Queensland is yes, that work has all been done, and it's available on a report on that website, the Queensland Anti-Discrimination Commissioner website. And once again, if you send me a link, I can send you a link to that particular website.
Oh, thank you.
You're welcome.
Hi, Chris. It's Bronwyn from Adelaide. Who did you meet with in SA Health? Sorry. Hi, how are you?
Yep.
Who did you meet with in SA?
We're
SA Health
working
or?
with, no, the Health Performance Council.
Health Performance
SA
Council.
Health Performance
Beautiful.
Council. Yep. Yep. They've
Okay.
commissioned us to start development.
Wonderful. All right. That'll help me in a lot. Thank you.
Good. Good.
Are you able to share this, Chris? Share this presentation with us?
Yeah, it's been recorded.
Well, I think it's all been recorded.
I know it's been recorded, yeah. So will it be on the website, or where will it be?
That's a question for Penny, not me.
Okay. Thanks.
Yeah. Penny's got the technological know-how to answer that question. I'm afraid I don't have that. But they've assured me that this is all being recorded and is available, including the ums and ahs at the start. Any other questions? Okay. Well, we might call it a wrap then, if that sounds right to everybody. If anybody wants to get in touch with me to talk about further, my contact details are on the screen, and we can take it from there.
Lovely.
Yeah, thanks very much. Thank you.
Thank you.
Bye,
Bye
from
all.
Perth. Bye.
Thank you. Bye.